Thank you so much for joining us today. We've got some people in the room with us here on Click Meeting, and we're live on Facebook now as well. So thank you so much for joining us. I'd like to welcome along Professor Dave Jones, who's with us today as well. Good afternoon, Dave. How are you doing?
I'm very well, thank you. A sort of typically rainy mid-August afternoon in Newcastle.
I'm afraid Scotland's not much better today, but I think it's fair to say that our summer is well and truly over.
Good afternoon, everybody around the world.
So I'm just going to get started. We've got some questions that have been sent in today, but also just a general reminder before we get started. So just to remind the patients that are joining us today that these Q&As do not take the place of a consultation with your own clinician. We aim not to provide medical advice, but to provide some general medical information. And also just to remember that Facebook is a public forum, so just be aware of what you're typing in the chat there. The details for the Click Meeting, if you want the privacy of the room, is in the previous post and you can join us.
Just to add to Mo's comment is that if in our discussions here there are some issues or questions that you might like to ask your clinician, then we would like to think we have done our job. And welcome to Slovenia, Andrea. Welcome.
I've just seen that in the room here. Yeah, that's brilliant. Right, so our first question today, Dave, is my most challenging symptom is joint pain. Rheumatoid arthritis has been ruled out. They're on 100 milligrams of urso. Should this help with the joint pain? And if not, what treatment can be offered?
Okay, good. So PBC is an autoimmune condition, so the immune system is playing tricks, and like a lot of immune conditions, once you've got one you can get others. So that's the background to it. So like people with thyroid disease, autoimmune thyroid disease, often have other autoimmune conditions. So it's true with PBC, and a lot of these conditions kind of tend to go together. So it's quite common to get joint problems with PBC linked to its immune basis. Okay. Now, we're not here talking about osteoarthritis. We're not talking about the wear and tear arthritis that happens later in life. We're talking about the inflammatory ones where the joints are stiff and ache, often earlier in the morning. You need to get the oil can out to get your wrists going. So those types of symptoms are very common in PBC. Okay. And what's also very common is what one of the things that in that story, which is rheumatoid arthritis, was ruled out. So everyone thinks got PBC, it's the immune condition, is this rheumatoid arthritis? Let's do the test, and it's not rheumatoid arthritis. But actually that's normal. It's almost never, in my experience, rheumatoid arthritis. But it sometimes has a pattern a little bit like it. So rheumatoid particularly affects the small joints in the hand. It can affect the hips and the knees. But so it's very common to get something that sort of looks a little bit like rheumatoid arthritis, but it isn't because the tests are negative. And then the other thing it doesn't do is it doesn't really damage the joints like rheumatoid does. So people, you will have been familiar with the image of people with, deviated fingers with rheumatoid and things like that. That's actually pretty rare in PBC, fortunately. But you can get this discomfort in the similar joints. Now, that frequently associates with Sjögren's syndrome, so dry eyes and dry mouth, very common in PBC, but actually it's usually dry eyes, dry mouth, and this type of joint discomfort. So those three frequently go together. So the kind of good news about the joint problems in PBC are that they are common, but they don't go on to cause real joint damage, but they can be a nuisance and certainly uncomfortable. So how do you treat it? You would not expect it to get better with urso, okay, because it's kind of a step up. So the link between these is a little bit, upstream of where urso would work. So I would not normally expect people's urso to help their joints. So what we tend to do is we recommend simple analgesics. So Brufen is fine. There's a myth out there you can't take Brufen with PBC. It's a myth, absolute myth. It's absolutely safe to take, and as is paracetamol, strangely. Paracetamol is only dangerous to your liver if you take an overdose. So low dose of paracetamol is fine. And generally speaking, you're better taking Brufen, a bit of paracetamol in advance of the problem. So first thing when you wake up in the morning. So don't wait to get discomfort. Give it in advance of that. So for most people, that's all you need to do. Regular Brufen and regular low dose paracetamol, often first thing in the morning, and that gets you going during the day. Now, we do see lots of patients together with our rheumatology colleagues. So it's the commonest kind of conversation between clinics that we have with rheumatology about practical issues. And so once it gets a little bit worse, then they have their own drugs that they would tend to use. And the dialogue is, we're thinking of using drug X. What do you think about it from a PBC perspective? And that's quite a useful conversation, because there are some drugs that seem to work well in our patients, and there are some drugs which in our experience don't work that well for the joint problem. So a drug called hydroxychloroquine is used a lot of times by the rheumatologist. My experience just doesn't seem to do very much, but they also sometimes use a drug called rituximab, which is an immune suppressant, which in our experience is actually brilliant for PBC symptoms and for the liver itself. So if it goes beyond brufen and paracetamol, it is worth going to see maybe just once a rheumatologist to get some specific advice about particular therapies. And it's the pattern and the blood tests and things sort of indicate which of those treatments it is. So it's not progressive, it's a nuisance more than anything else, and it usually works quite well with therapies. The one caveat to that is that there are some other more tricky types of arthritis. So one of them is psoriatic arthritis, so arthritis associated with psoriasis, if people have got a little bit of that. And we know that psoriasis is actually commoner in PBC. So just occasionally get a little bit more complicated ones. And that's one of the reasons why it's worth getting a rheumatologist maybe to have a little look, because it will work out if it's something that's going to read its own specific therapies. Generally speaking, with one of these things is I speak as a kind of somebody who very much specializes in an individual disease area. I absolutely recognize there are equivalents of me in other disease areas. And so, simple kind of, common sense stuff we're happy with. But actually, if you've got joint problems, you don't want me to manage them. You want the equivalent of me in joint disease to manage it. And so very much it's teams of people talking to each other, managing problems once it gets beyond a single thing. People want to go to a clinic and have one discussion that covers all of those things, but we are in a super specialized world. And in a sense, I always ask myself, would I want a rheumatologist to manage complicated PBC? Probably not, because they don't know it like we know it. Well, I return them the same compliment.
Yeah, no, that's great. Thank you. Our next question is around fibrates. What are your views on the use of fibrates as an add-on to urso? And is it used? It's used in Japan and France as preventative treatment. It's cheap with limited side effects.
Fibrates. So I can tell you, if I could see the future, I wouldn't be here, because I'd put my entire very small fortune on the horse that's going to win the 4:30 at Kempton Park, knowing the result, and therefore be very rich. But in the absence of that, one tries to see the way the world is going in PBC. Okay. And I would like to think, myself and colleagues in the foundation itself have been ahead of the curve with a lot of these things. So sometimes people can slip into, what we do is fine type of kind of looking backwards, and we've always looked forwards. And I think it's useful to do that, because it helps you understand what you know and what you don't know and where the gaps might be. Okay. One of the things that people like all of us do is, and we had the summit meeting, earlier this year. And what happens in those sorts of meetings is we do see the information that's going to come out next year and the year after. So we get a view of what's coming down the line, in advance of it being sort of common knowledge. Okay. So with that backdrop, the future for me, for PBC, pretty much beyond any, the very mildest cases, is actually going to be the combination of urso plus obeticholic acid plus fibrates. Okay. And I want everyone here to say, here we are, 17th of August, 2023, 5 years time, when that's standard therapy. I want you to look back and say, Mystic Jones saw the future, and it's triple therapy. So why do I say that? 70% of people in the studies are normalized, completely normalizing their blood tests. Okay. Now, that's not response mode. That's not above a certain level. That's not alphos below 1.67 times upper limit normal. That's normal. Okay. And there are some histories in medicine where, hepatitis C was a classic example, where you started with 10% full response, and that was great, but not brilliant. And it was 20%, that's a doubling, but it's still only 20%. And all of a sudden, once it was over 50%, people's mindset changed completely, because you were more likely to completely respond than not, and therefore we're on the finishing straight, if you like. And I think that's where that is going to be. And I think before too long, and that's going to be, and I can tell you now, the commonest combination of treatment we start now is that triple therapy. Okay. So I think that's and debates therefore about OCA or fibrate are probably going to become a little bit redundant, because I think we'll have moved beyond that. You know, can't argue with 70% completely normal. Okay. And then, you know, I think the debate is going to be, you know, doing it early enough in the disease and not waiting, and all of those various different things. So I think, in a sense, that debate's going to become a little bit redundant. So what I think about fibrates. So fibrates clearly improve liver blood tests in PBC. They clearly do that. And we, in fact, we in Newcastle picked up on the Japanese data. Japanese did a lot of work on this 20 years ago, and we picked up on that. So we've been using fibrates for 20 years for PBC based on that. So, you know, there's no success, you know, this is an overnight success that's been 20 years in the making. So we got a lot of experience of that, and they undoubtedly work for improving the liver blood tests. Okay. OCA, one of its limitations is around causing itch, which is a manageable issue, but we do see it, and it factors into our thinking when we're using second-line therapy. Fibrates certainly don't cause itch, and they are probably beneficial for itch. So that is a distinction between them. Okay. Now, so why don't we use fibrates in everybody? They're a lot cheaper than OCA. Well, several reasons. One is, I don't think ultimately they're as effective as OCA, and the trials will say they are, but when you look at the trials, you'll see that the people treated with fibrate tend to have much less severe disease. So if you start with your alkaline phosphatase up by 100 points, then you are much more likely to return to normal than if you do when it's 200 points up. It's kind of common sense. So when people have used fibrates, they have tended to do it for whatever reason in people with less severe disease. And certainly you look at our practice, we probably until recently used as much fibrate as OCA. And actually our figures are exactly that. People tended to have much less bad biochemistry when we gave them fibrate. So you do need to just be aware of that. They have tended to be used in people with less severe disease. There is a concern about obeticholic acid in people with advanced liver disease. And I think that's a legitimate concern. And we will be very cautious in people with cirrhosis, but we would use exactly the same caution for fibrate. So that is to do with the impact of these drugs in people with advanced disease. So I think that's an equal caution. So what about itch? Well, as I've said in many of these calls, we run a dedicated symptoms clinic on a Monday morning. So we've developed a whole clinic that just looks at symptoms. 2/3 of people, their main problem is fatigue. 1/3 of people, their main problem is itch. And we see a lot of people all around the country with really difficult itch. Okay. I personally think the benefits of fibrates for itch are a little bit overstated, okay? Because it is not a game-changing treatment for difficult itch. So we try it, of course we do. We want to treat people, but it is not one of the drugs that I think is going to really make a difference in people who've had a real problem with itch. I think it's a little bit hyped, if I'm honest. And there'll be people on the call who've done really well with it. And that's, you know, there are people, but for really bad itch, it's not, I don't think it's the answer to itch. I think it's part of the answer to itch, but we still need better therapies for very complicated itch, you know, as lots of people are aware. What about side effects? We know a lot about the side effects of OCA because there has been something like 10,000 patient years of follow-up with the drug. So that, you know, if you have the drug for 1 year, that's 1 patient year of follow-up. So we have 10,000 patient years of follow-up for OCA. Okay, every single person getting OCA in the world the anonymous information about what's happened to them is still being recorded, so we know what happens. That's why we know itch isn't as much of a problem as people thought it was. That's why we know you've got to be careful in cirrhosis. And what we know is that there are no nasty surprises with ochre. There's nothing that comes along after 5 years and suddenly causes you problems, because we're still following people. You know, the people who've been on ochre for longest are probably about 10 years now after the trials. Mm-hmm. So, you know, basically after the first year, if you're going to have problems, you have them the first year. After that, nothing much happens. And it's been very carefully looked at as part of the licensing process. Now, fibrates have not been followed up in the same way because they're not licensed for use in PBC. So nobody, you know, Intercept don't collect that information out of the goodness of their heart. They collect it because they've been told to by the regulators. Nobody's done that for fibrates because they're not licensed. So we don't have that information. We don't know what the problems are. And don't ever mistake not knowing that there is a problem from knowing there is not a problem. They are very different, because it may be that it's brewing up and nobody is aware of it. And I said to you that we, until recently, used equal amounts of fibrate and ochre. Now it's about 9 patients going on to ochre for 1 for fibrates. Why is that? Because we're seeing kidney problems with fibrates over a long period of time. So about 1 in 10 the patients we give fibrates to has to stop them because of kidney issues.
Okay.
And that's a concern, okay? Because particularly if nobody is watching, and it's typically happens about 5 to 10 years in the therapy. Nobody's watching at that point. GPs aren't watching. It's if you're going to get itch with ochre, you get it in the first 3 weeks when people are watching. If you get a problem at 5 years, people aren't watching. So I think we just need to be a little bit careful about that, because that may be a problem that we're brewing up for the future. And I think if we are going to use fibrates really widely, then we do need to watch them very carefully. Now, there's some research going on literally at the moment to work out, is the kidney impact of fibrates reduced if you give it with ochre? So what about my combination? And then the other question is, what happens to itch? So does fibrate control the itch that ochre might have given? And our suspicion based on experience is it probably does. And so that's very good. So I think I'm cautious about, there are people in Europe who will say we should give everybody fibrates because they're really cheap and they're the answer to PBC. And I think that's a little bit simplistic, and I would just take a step back and be a bit cautious. So I think they are very valuable drugs, but, you know, there is no drug. You know, aspirin, everyone goes, aspirin is a miracle drug. It's easily available. It's really cheap. It stops you getting heart attacks. It's brilliant, but it also kills people through GI bleeds. And just need to be aware of that there is no such thing as a free lunch, and it's who's watching and what are they doing with that information. So I think the next part of the journey will actually be around combinations. I think fibrates, I'm a little bit cautious they're being used more widely if people aren't going to carefully watch what's going on. The other thing about cost is, I find that very interesting, is that I believe PBC patients, and I know Robert and Mo do from the foundation because we've talked about it, I think you, as patients with PBC, deserve the best treatment there is available, okay? You don't deserve the best treatment that's available, provided it's really cheap so we can save some money for other patients. Because I can tell you, people with hepatitis, prescribing drugs for hepatitis C are not having that conversation. They do not care about the cost of the drugs. They give the best drugs. They do not give the cheapest drugs. And I'm slightly surprised by the argument that PBC patients don't warrant the best treatment because we've got to save money, because that's not a discussion that's happening for other diseases. And I use the best drug for patients. And if there are equal drugs, I will use absolutely equal drugs. I will use the cheapest drug. But I think it's a slightly strange debate, and I always pull colleagues up when they do it. Last thing just to say about the cost of ochre. The more it's used, the cost will go down. That's the nature of these things. But certainly in England, we have a thing called NICE. People from England will know about that, National Institute for Health and Clinical Excellence. What they do is they evaluate the effectiveness of drugs and the cost of drugs, and they then decide whether their use is warranted because they are worth the cost, okay? And they do that and I don't have to, because they're experts on all of this, and they approved ochre for use in PBC without any question. So when people say we shouldn't use it because it's expensive, well, the experts, and they are like hawks on this, say that it is worth using, and actually they know more about the cost and benefit and risks of things than I do, and so they guide doctors. So nice guidance for the UK, for England, is that people with higher risk PBC who don't respond to urso should have ochre, and they do not recommend the use of bezafibrate because it's not licensed for that indication. I think till that changes, our practice is largely ochre, but as I say, the future will be triple therapy. It is quite important. So therefore, if you do have a debate with your doctor about second line therapy, they should be discussing the options with you, okay? And the options are no treatment, ochre, bezafibrate, or experimental treatments. That's pretty much the options. We would not tend to start people on triple therapy unless they had, really bad liver function. We would tend to do it 1, 2, 3. And if they suggest bezafibrate, ask them why. On what basis? Is that about you and your disease profile, or is that about a desire to save money? In which case, do they do that for every patient with every disease, or is it just you and PBC? That's always they'll shuffle a little bit with that. We do use bezafibrate. Where we use it is because where people got really bad itch, because we want to see second line therapy with itch control. That's a better bet than ochre, and usually that then allows us to add in ochre down the line. So that's how we tend.
Actually, touching on something you mentioned there, Dave, you were talking about kidney disease. So we've actually had a patient ask us if PBC patients are likely to experience chronic kidney disease, and if that could be a possible autoimmune crossover. It doesn't mention what medication they're on, so if they've been on fibrates, it doesn't mention that. But just tying into what you were mentioning there, I just thought we would jump to that one.
Yeah, really good question. So we see very little kidney disease in PBC, very little. However, kidney disease happens in the population. So remember, having PBC doesn't stop you getting X, Y, and Z. Okay, so sometimes some conditions are neither commoner nor rarer in PBC. Some are commoner, some are rarer. In fact, breast cancer always surprises people. You have around about a third the chance of getting breast cancer if you've got PBC than if you don't have PBC. Okay, and that's an interesting observation. Doesn't stop. Please do not take that information and not have mammography and all of those things. Absolutely not. But, people worry that everything piles up, and it doesn't actually. It's very interesting. There are then side effects of treatment. So sometimes you can get a problem that's not to do with the disease, but it's to do with the treatment disease. So a lot of steroid side effects, for example. In liver disease, you will see in general quite a lot of kidney disease. So you have a thing called hepatorenal syndrome, which is the combination of liver and kidney. You never see that in PBC. In all of the, I know this is, I'm about to go on holiday. I've got a meeting with Mo after this, and after that I'm on holiday for 2 weeks, and I'm 60 the day I come back. 60. There you go. So anyone who wants to can put a message in the chat saying that's impossible because I look so young and vigorous. Anybody who wants to do that is able to do that.
I'll delete those comments as they come in. Don't worry.
So I started PBC management in 1991. I have never seen hepatorenal failure in a patient with PBC since 1991. Okay, and I have a test, therefore it doesn't exist. That's specifically kidney disease caused by bad liver disease. We do see, and this is a lover for lovers of small print. I've never mentioned this in any of these Q&A sessions. There is an incredibly rare kidney disease called renal tubular acidosis, or Fanconi's syndrome, and that is seen in PBC, but we're talking about very, very small numbers. So there is one kidney disease that we used to see. Now, interestingly, we again never see it anymore, and I think this is something that might be we talked about the joints not being treated by urso. I think this might be something that is treated by urso because we just never see it anymore. So most of the people who've got kidney problems with PBC have it for other reasons, and that's to do with age, the presence of diabetes, hypertension, family, urinary tract infections in the past, lots and lots of different things. But bezafibrate is on that list. So we look at a thing called EGFR. So that's the test we use. It's glomerular filtration rate. So that's why I say GFR. Okay, because otherwise it's glomerular filtration rate. That's the best measure to look at. The magic number is 60. If it's below 60, you shouldn't take fibrates, and that probably needs looking at from a kidney point of view. But it's usually not connected to PBC. But we would be very cautious in anybody with fibrates who's got any abnormality in their GFR. So the answer is it's very unlikely to be the PBC, but the PBC or PBC therapies may well be in the background. Okay. People often ask about diabetes. Diabetes is also not associated with PBC. It's associated with the age that PBC patients frequently are, if you like. So type 2 diabetes affects people in their 60s, 70s, 80s particularly. And that's an age group for people who do have PBC. So that's an age association, if you like.
Mm-hmm. That patient also asked, and it's just touching on what you'd mentioned earlier about the rheumatology, if there were any kidney specialists near Wrexham, so I can look and see if we can hook them up with something near them. I'll do that.
Yes, so all hospitals will have a kidney specialist, they'll have a rheumatologist. They're more likely to have those than they are to have a specialist liver person. This is not, for all of these things that, usually this is just a single visit to run some tests, but then it's about somebody then watching it down the line. And I think they would always prefer to know early with these things. So you do just have to watch with the kidney a little bit around drugs. I think that's an important point.
Mm-hmm. No, that's great. So we have a patient who suffered a stroke recently, and they're asking if having PBC has put them at higher risk of that.
No. So it's one of those things where it's to do with other risk factors, which may be commoner in people with PBC, but only because they are the age and gender of PBC patients, if you know what I mean. Mm-hmm. So stroke is a disease that particularly affects people kind of, again, 60, 70, 80 onwards. And so that's why you will see it more than you would in, say, autoimmune hepatitis, because autoimmune hepatitis affects a much younger age group. Okay, so it looks like an association, but it isn't an association. It's indirect association. So what about vascular disease? Let's broaden it out a little bit. So strokes and heart attacks, are they commoner in PBC than in the ordinary population? No, that's been looked at pretty extensively, and the answer is no. And we really don't see those frequently at all. So again, what do I see in my clinic sort of way of thinking about it? They are not associated. We do not see those with any frequency. In fact, most people with PBC are women, and women have a lower risk of those things. So that's important. So that's one of the reasons we don't see very much. The main risk factors for those are three. One is smoking. And that's easy to manage. Don't smoke. Weirdly, PBC patients are more likely to smoke than the age and sex matched non-PBC people in the population, but you heard it here first. Don't smoke. It's not good. Put all the money in a pot, okay? Every time you don't buy a packet of cigarettes, put the money in a pot, and then at the end of the year, do something really nice with it, or buy something really nice, and then you realize how much money you've wasted on smoking. Family history, so nothing you can do about that. Diabetes, so four things. Diabetes, so obviously checking for diabetes and managing it. And then the fourth thing is cholesterol. Now, cholesterol, long debates in PBC because cholesterol is frequently elevated, but it is usually the protective form of cholesterol, not the harmful one. However, having PBC doesn't stop you from having an elevation of the good cholesterol, but also elevation of the poor cholesterol. So there needs to be a little bit of thought. So don't smoke, okay? You can't change your parents, no matter how much you might want to. My children always wish to change their parents. You can't change it. So you can stop smoking. You can't change your parents. Sorry, we're up to 5 things. Blood pressure is very important. So have your blood pressure checked, have that managed appropriately, and then have some smart thinking about your cholesterol, which needs to be a little bit more than just the headline number, because most people, the headline number is high, but actually it's not the risk form. So basically it's attention to detail. With all of that, I have to say, we just don't see heart problems or stroke in any frequency with PBC patients. So it's attention to detail, it's not PBC.
Okay, more general question next, just asking if it's safe to get the flu vaccine when you have PBC?
Yes, absolutely. We had this debate when we started these in 2020. Don't know what happened in 2020 that made us do these things. Something happened in 2020, can't remember. We talked a lot about vaccination, correctly. We talked a lot about vaccination. And I said something which I will say again, which is that there are 2 things that have transformed the health of our population in the last 200 years. One of those is clean water provision, and then the other is vaccination. It's not antibiotics and statins and, etc. It is being able to drink clean water, and it is vaccination. So on balance, vaccination has been an absolutely undoubted benefit. However, vaccines do stimulate the immune system, and that in some people will potentially have a consequence. But on balance, and benefit. And what events have told us is that what the COVID vaccines did was stop people getting really bad COVID and dying of it. Okay, in simple terms, they did not protect anybody from getting COVID. Everyone will have a story of getting COVID after the vaccine. That's not the point. The point is, didn't end up in ITU. Mm-hmm. So vaccination in general is a good thing. There is nothing about PBC that means you should avoid any vaccine at all. It's a little bit more complicated for those people who've had a liver transplant or are on immunosuppression after, so there are some people who maybe got overlap and are on steroids and azathioprine, MMF, drugs like that. You have to be a little bit more cautious. But remember, those people, infection is more of an issue. So again, the need to do it all is there. But it becomes a little bit more nuanced, though. There are some vaccines you might want to avoid. And then there are, some vaccines you absolutely, want to have, and on balance, they're very good. So generally speaking, all vaccinations are fine in PBC. People will have heard me muse. I'm not sure that's the right word. Waffle on is probably more accurate, but will have heard me waffle on about why was it that PBC patients just didn't seem to get bad COVID. And we talked about this quite a lot from really early on, because everyone was really worried and shielding and all of those things. And we were giving out guidance, and we were thinking we just didn't see any problems. Okay. And we were really interested as to why that was. And we wondered, is this because people are really attentive to detail and good at shielding, or is it? And then we thought it was all just a bit, we were seeing people with COVID, but they just weren't getting bad COVID, which is interesting. So that's not shielding. So then we wondered, is it that something, and if people who come to the clinic and heard me talk about it or read the book or whatever will know we talk about the immune system being overactive. So, and that actually it's strange. Why do we have genes that allow our immune system to be overactive? Well, actually, maybe they're beneficial in the circumstances to control infection. So sickle cell anemia that people will be familiar with, potentially it's a genetic condition that affects people of African origin. If you've got 2 versions of the defective gene, it's a horrible condition. But if you've got one version of the genetic protective gene, it protects you against malaria. And that's why the gene is in the population. Because you've got one copy of it, you'll survive malaria. And that makes a big difference in the population. So was there something like that going on? We always talk about PBC patients having a really aggressive immune system. It's a bit angry, spoiling for a fight. But maybe that was beneficial in fighting the infection. And it turns out that's probably not the case. It turns out 2 things are true. One is PBC patients genuinely did appear to have a lower risk of bad disease. It wasn't just kind of a chance observation that wasn't true. And the answer appears to be URSO. And URSO, amazingly, appears to protect you from COVID infecting the lining in your nose. And there was a project done by a few centres, we were involved at all, and they are now looking at Urso as a protective therapy for people with blood cancers and things who don't respond to the vaccine. That's the problem. Vaccine is really useful, but if you don't respond to the vaccine, then Urso is safe and effective. And, you know, it's a small world, isn't it? That there you go. So it wasn't the disease, it wasn't you looking after yourselves, it wasn't the genes, it was the Urso. Who knew?
Brilliant though. Guys, I just wanted to take the opportunity as well just to say that Dave's joining us in Edinburgh for our conference in September. Yep. So over the PBC Day weekend, 9th and 10th September, we're having a patient conference in Edinburgh, which is open to patients and their friends and family. So you'll find details of that on our website. And we've also just released information about how you can join it virtually as well. Excuse me, just worth of note that the virtual attendance won't be the full session. Because there'll be breakout sessions that won't be part of the sessions that we'll stream live during the event. But please have a look at that, and if you're able to come along and join us, that would be amazing.
Absolutely, it'll be very jolly, and we have great discussions at these. Real opportunity to ask, you know, all of the questions. So looking forward to it.
Yeah, no, and the agenda is shaping up really well. We have a dietitian coming along. We have a lot of clinician input as well. In addition to yourself, Dave, we have an occupational therapist, and we've obviously got self-care sessions from the foundation staff. So it's looking great. Please do come and join us. So our next question is about, I'm going to see if I pronounce this correctly, modafinil, used to treat fatigue in PBC. Yep, that's the one. Used successfully to treat fatigue in PBC. If so, should it be used when required, or is it a regular daily dose that's recommended?
Okay, this is why I love these sessions, because that's a brilliant question, and that encapsulates the thinking about, and I'll explain what modafinil is in a second, but that encapsulates exactly how you should be thinking about this drug in a way that no clinician I've ever come across gets it. Okay, and that's why I love these things, because that's a brilliant question. So what's modafinil? So modafinil is a drug that's called a cognitive enhancer. It's a horrible term, and it's used in America for conditions like ADHD, and so it's a licensed medicine. And what it basically does is stops you going to sleep. Okay. And it was invented by the Americans in the Vietnam War so that people didn't go to sleep in the jungle, and it's pretty effective at that. And it was picked up by American college students to allow them to cram for exams by never going to sleep. So it's a bit like Red Bull, but not as horrible to drink. My children do nothing but drink Red Bull, don't understand it, but there you go. So other energy drinks are available. So it does what it says on the tin, if you like, which is that it prevents people going to sleep. So what on earth has that got to do with PBC? Well, when you look at sleep abnormality in PBC, there are two sorts to it. One of them is nighttime sleep abnormality, and that's usually driven by itch, actually, in our experience. So people can't go to sleep, or they get woken up because they itch, and once you wake up, you can't go back to sleep, right? And then you've got daytime sleepiness. So that's the reverse. At night, people can't sleep, but during the day, they just go to sleep. And it's very striking, very, very striking that this affects some people. It's called daytime somnolence. And it's very common in people with fatigue. Now, the process, remember, it isn't necessarily about going to sleep, because you can prevent yourself going to sleep, but it's whether you would, the sense that you want to go to sleep. That's very common in PBC patients with fatigue, okay? Mm-hmm. So we made that observation 15 years ago, that there is this tendency towards daytime sleep. And then there is also, slightly not connected, this general issue with sleep, which is more linked to the itch. And so we spoke to some experts in sleep. Goes back to what I said before. You know, I accept there are people who know much more about things than I do. So let's go and talk to them about what they do. And that's how we investigate sleep. Go to sleep clinics and things like that. And this used to be very difficult. People had to come into hospital for sleep studies, so now technology is brilliant. So you can go home with a watch from the clinic for 2 weeks, and it'll record your sleep patterns very accurately. So it's one of these areas where technology's got really good. So if people are sleeping during the day, then it's really worth looking into their overall sleep pattern, okay? Because if you can stop them sleeping during the day, it's usually because you've cracked the problem. And obstructive sleep apnea, which people will be familiar with, where you wake up at night, stop breathing and wake up, and all of those things. So there are lots of, it's quite a specialist area. But there are some people with PBC who just want to sleep 16 hours a day, okay? And they want to sleep during the day, okay? And that is strongly associated with fatigue. So those people have terrible fatigue. And so the question we had was, what can you do? And modafinil is a drug that is used by sleep doctors to prevent people sleeping during the day when they're doing that. Because you take it, it will stop you sleeping. And what then happens if you do that was the question. So we started giving modafinil to people as licensed drugs, you know, under the guidance of sleep doctors. We did that, and it's really effective at stopping people going to sleep and during the day. And it also, in those people, treated their fatigue. So their fatigue was much improved, right? And I'm being very careful what I'm saying here, because this has been quite significantly misinterpreted by people. So in people who have daytime sleepiness, significant daytime sleepiness, then modafinil will reduce that. And it will also, at the same time, as a result of reducing that, reduce the fatigue. So for that group of people, it is a really powerful treatment. Modafinil does not work for people who don't want to sleep during the day. It is not a treatment for fatigue. It is a treatment for daytime sleepiness that happens to improve fatigue in people who have daytime sleepiness. Do you get the nuanced difference? So it is treating daytime sleepiness, not fatigue. There's a bonus, though, a bonus that you will treat the fatigue as well. Okay, so that's the important thing. And there were subsequent trials and people went, oh, it doesn't work in PBC fatigue. No, we never said it did. It works in daytime sleepiness, not in general fatigue. The other thing to say about it is that people hate it generally, and we use it very rarely because people hate it. And the reason they hate it is it's really difficult to get the dosing right, because it ends up making you speed it up. So if you take it too late or take too high a dose, you can't ever get to sleep.
That's just what I was thinking. How do you manage that to then be able to manage it?
But of all the people who take it, PBC patients do it the best, because you kind of are quite receptive to your body and senses. So when we're using it, we play around with the dosing when you take it. So often people will, you know, take it first thing in the morning or whatever you do, but don't take it too late in the day. So we use it in tiny numbers of people, and it's really useful, okay? And we use it in two ways. So we use it in two settings. One is in people who are literally in danger of losing their jobs because they're sleeping at work. So I remember a lady who just couldn't stop sleeping on a computer, and she was on a final warning at work. And for her, it was life-changing because she could continue working, supporting her family. So there's a condition called narcolepsy that people might have heard of, where you really do fall asleep at any situation. Really bad daytime sleep in PBC can be almost at that level, and modafinil is used in that setting. So where people just can't work because of it, then it actually, and then, you know, then it can be life-changing. The most effective use we use is in people who actually never end up taking it. And you'll think I'm mad, but let me explain. The other group we use it in is in people who are terrified that this will ruin something that really matters to them. And I always talk about mother of the bride as being the absolutely archetypal situation, because I've seen it several times. Only daughter's getting married. It's the one time you'll be the mother of the bride, but I just won't be able to get through the day. And it really is worrying me, and potentially there's kind of a big knock-on effect. And those are people we give a little supply of modafinil to. We suggest they try it and see what it feels like. And then on the day, they take a little pot with them. And if they need to, then they can take it and they can enjoy the day. And yeah, they'll feel a bit odd the next day, but you can manage the day, and it guarantees you'll be able to stay awake. And you know what? They never take it. They never take it. But owning the problem, those of you who heard me talk and the book and things like that, you'll hear me talk about own the problem, own the solution. There, they own the problem and they own the solution. And actually having the potential to do it if you need to do it often means you don't need to do it. And that's why the most benefit comes from people who actually never end up taking. And it's really powerful. If you absolutely have to, then you can, and you will wake up. And that actually allows people then to make their own adaptations around it. So it's a brilliant drug. apart from when you actually use it, when people actually hate it. But it's just useful in those very specific situations. Now, it's like a Ronnie Corbett story, this, isn't it? For those of you old enough to remember Ronnie Corbett, like I am. Go off on a tangent. The end of the modafinil story is that we got a phone call. I don't think, Mo, you probably don't know this. I got a phone call from a company in Sweden to say, we saw you've written about daytime somnolence, and we use a thing called the ESS, the Epworth Sleepiness Score, the ESS. And they said to us, you're the only people we've ever come across in liver who use this tool. And we've been doing some work on a drug that reverses daytime sleepiness. And we prove it reverses daytime sleepiness using our drug. Okay. Is this potentially going to be interesting in PBC? Okay. Now, I think if you understand daytime sleepiness, you understand fatigue in PBC. Okay. I think they are inextricably linked. So the answer was yes, 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 yes. And that is the work that we're doing with Umacrine, the company. So you will be aware of the work we're doing about validating a measure with the foundation to be able to measure sleep. So this is a trial of a completely new drug to treat fatigue, and it is based on the ability to reverse sleepiness. But the important thing is it does not do what modafinil does. It doesn't do it by speeding you up. It does it by reversing the process. Now, drugs, who knows what comes out in trials? That's why you have to do trials. But this is so very exciting because it goes to the heart of the problem. And that trial will genuinely be launching in the next couple of months. And the foundation is absolutely front and center with all of that. But when that trial comes along, that is the end point of the modafinil story, because it does what modafinil does, but it does it by working to correct the problem rather than just bypassing the problem. So modafinil, bless it, has played a big role in PBC potentially, because it's what got them to spot that there may be potential value. Did you know that, Mo?
I didn't know that first bit, no.
Yeah.
I didn't know. Right, I'll move on to our next one. We've got one question actually that I've got in my list here that's been sent in, and I also see it here in Click Meeting as well. So how is fatty liver diagnosed?
So fatty liver disease is not connected with PBC at all. So it's neither commoner nor less common in PBC patients, but it's a condition that typically affects people in their 60s, 70s, 80s, etc., etc., etc. It is, however, in the background as because it can coexist with PBC, and it can lead to people missing the diagnosis of PBC. And so it's an important question. So it's a reasonable question. It's a very interesting sign of our times that in the past, everybody diagnosed with PBC had previously been misdiagnosed with alcoholic liver disease. And now the world has changed. Everybody diagnosed with PBC has previously been misdiagnosed having fatty liver disease. It's because it's become the fashionable disease du jour. Fat in the liver is common in the population. That's not fatty liver disease. That's just fat in the liver. That can turn into fatty liver disease. And so the danger is that people can put two and two together and make five. So find fat in the liver, find abnormal liver function tests, don't diagnose PBC, and therefore miss an opportunity to treat it. So you look for fatty liver disease with an ultrasound scan. So an ultrasound scan that many people have had, the liver becomes very much more reflective. We call it bright. So much more is reflected. So it just looks very shiny, and that's how you diagnose fatty liver disease. So the question is, if you've got a fatty liver and you've got AMA, is it fatty liver disease or is it PBC? Well, actually, that's not a question that's worth thinking about, because if you've got abnormal liver blood tests and you've got AMA, then we know that people in that category benefit from treatment for PBC. Okay, so the trials tell us treat with urso. Okay, urso probably benefits fatty liver disease as well. So it's a win-win situation. There is nothing to be, lost by using urso, because it will definitely help PBC and it will probably help fatty liver disease. So where people have AMA, abnormal liver function tests, and look like they've got fatty liver disease on ultrasound, then I would just treat them as if they had PBC and see what happens. So it's as simple as that. If you really want to know if somebody's got fatty liver disease, you then need to do a liver biopsy. But the question is, what are you going to do with it, with that information. So we would very rarely think of doing a liver biopsy to answer that question. The vast majority of people in that sitting have PBC with a little bit of fat in their liver. Now, anti-nuclear antibodies, which the antibodies you get with autoimmune hepatitis, they can be caused by fatty liver disease. So that test can become falsely positive with fatty liver disease. So it's a common question, have people got fatty liver disease or autoimmune hepatitis? And that is tricky, because in that situation, the treatment with autoimmune hepatitis is steroids that will make the fatty liver disease worse. So in those situations, we will always do a biopsy. If it's AMA, we would never do a biopsy because the treatment will work for both. But unlike anti-nuclear antibody, we almost never see AMA caused by fatty liver disease. So it's a misapprehension that you do. So in practice, it's usually very easy. And if in doubt, you treat as PBC and see what happens, because the treatment will work for both.
I see. Okay. Just aware of the time here as we're leading up until 3 o'clock. I'm just going to ask about, it's two parts of the same question, but it's a general one which I think can be quite useful for patients. If someone forgets to take their urso dose, should they take double the next time? And what are the weight ratios for deciding what amount of urso to take? So I'm just going to remind about our urso calculator, which is on the website, which will give you all the details about weight and how to calculate your dose as well. But we'll take the first bit. So if you forget to take your urso,
Mo,
should you double up?
Mo, the guy who used to do this, can't remember his name, the other guy, I don't know where he is these days.
No, don't know.
No, he would always wave the calculator at this point.
Oh, I don't have one to hand.
There
No,
you
that's
go.
terrible.
So the calculator would always be at hand to show
I feel
people.
I should have a Blue Peter job there, yeah.
So what we're talking about here is that your urso dose is adjusted by your weight, okay? And you should take 13 to 15 milligrams per kilogram, which is a little bit difficult to work out in your head. And the foundation's produced a really simple calculator, helps people get it right, really helpful. It's on the website. There's a physical version. I'm sure there'll be a whole pile of these at the members conference. So
there will be, yes.
Another reason to come along. So do get the dose right. And remember, unfortunately, our weights fluctuate over time. Unfortunately, so sometimes people can end up being a little bit underdosed. You know, those times in your life where your clothes seem to have shrunk, right? We've all been there, right? So get the dose right. If you miss a dose, should you double up? No. Okay, no need to. Urso takes a really long time to get into the system, takes a really long time to get out the system. If you stop taking it, it would still be there for 3 months. So one day just makes no difference at all. If you go on holiday and you forget to take your Urso, don't go trying to get a prescription somewhere. It will make almost no difference to the levels in your body, even a week or 2 weeks. So just pick it up. It's not harmful to take a double dose, but you don't need to do it. Just pick it up. It's not. There are some drugs like blood pressure treatments that if you miss a dose, it can be dangerous. And there are some treatments like Urso, it makes not a jot of difference. And Urso is not a jot of difference.
Okay, that's great. Right, thank you so much, Dave. I am going to wind us up.
The other guy.
What was that?
Whatever happened to that other guy?
I don't know. I don't know. No.
Yeah. Right.
He is the problem that I have high blood pressure though. So we'll just keep him to the side at the moment, I think. He will also be at the conference, special appearance at the conference. All of the foundation staff will be at the conference. And there's quite a few of our volunteers coming along, obviously. I've been patients as well. So it would be really lovely to see as much patients as possible.
So just can I answer Caroline's question? Any preliminary findings from the Oaks trial? For those of you who don't know about this, this is the first of the new generation trials to target symptoms specifically. This is brain fog being targeted using obeticholic acid, not to improve liver blood tests, but to treat brain fog. And the answer is sadly not. We don't crack the data until everybody has been recruited. We're about 3/4 of the way through. It will be next year, and then we'll be able to share some information, and then we will roll straight on from Oaks to the trial of golexanolone, which is that drug I mentioned by the company Umacrine. People will roll straight onto that trial if they want to do it. So thank you for those people who've taken part in Oaks. It won't report for a little while yet. So we're not ignoring the question. It's just we don't have any information until the very end of the trial.
I would just like to say that there's lots of messages coming in, not just in the room here, but also on Facebook as well, to wish you a very happy birthday when it comes. And
Thank
also
you.
somebody noting that you look 40. So I'll message them afterwards and just make sure that they're all right and see if there's anything we can do for them.
So I'd just like to thank Mrs. Jones for that message. That's very helpful. You're very kind. I to be honest, a lot of people are surprised I'm 60. I mean, I'm not just saying that. A lot of people are surprised, but the years creep up on you, you know. So, but I'm not going anywhere yet. But I'm just, you know, I'd forgotten I was 60 until I have high blood pressures, and Mo and I maybe it's working with Robert. I don't know. Maybe there's a common thing there. But I have high blood pressure, and I did my NHS prescription, you know, prepayment like you do. And they said, you don't need to do this for a whole year because you're going to get a free one because you're 60. And that was, and then I got sent a whole load of Saga stuff, you know, and you know, that's it. But one of my colleagues who's 64 says the rail card's quite useful. So there you go. So I thank you for whoever said I didn't look at a year over 40.
And lots, as I say, lots of birthday messages as well, which is really lovely.
Thank you very much.
Thank you
and
so much for
apologies if
joining
we've not
us.
been able to answer the questions. We get a lot of questions, which is why this is so brilliant. And anybody, I'll be there for most of the conference. So, you know, come along and, you know, just talking about PBC and thinking about PBC is my hobby as well as my job. So just come along and ask, you know.
Just to say, any of the questions that are on Facebook that we haven't got to today, or any of the ones that have previously come in, they'll be rolled over for next week. So we will get to them next week. Yes.
Who's doing it?
We have Dr. Robert Gish next week.
Oh,
and
he's
it's not
very nice.
2 o'clock. It's 3 o'clock. So that was well remembered to actually mention that. We're not 2 o'clock next week. We're 3 o'clock next week. Or is that
that's because he's on the West
Coast?
Now you've
got me questioning myself.
That's a little early in the morning for him.
Yeah, actually, I'm not sure that is next week now. So can I blame brain fog on all of this? I will check the socials to find out what's happening, because that might be the week after. I might be a week ahead of myself. But we do have doctors scheduled for the next 3 or 4 weeks. We've got
just to say what I always say with these is that this is one of those things that we just did, you know, on a whim during COVID that has turned out to be so incredibly valuable. People are very kind for saying they find it valuable. But just so you know, the clinicians really enjoy doing this. This is, you know, only not a labor of love, because it's not a labor at all. We really find this valuable and enjoy it, and it's a highlight of my month when I do this, to be honest. So it's one of those things that you sometimes wonder, why did we not do it before? But I guess it's the online stuff. We just got used to it.
When I've recently joined the foundation, and this is one of the jobs that I've taken over, I've loved doing the Q&As, and I've been a PBC patient since 2007, and every week I learn something new. So it's absolutely great.
And it's also, you know, different people, different perspectives, different worldview. You also realise from that sometimes there isn't a single answer, you know, and getting different views on it is actually really useful. And if that does happen, very useful for us to discuss that. So, you know, if Dr. whatever said they wouldn't do that, then, you know, maybe itch treatments, which would use that. It's a useful thing to talk it through, because, you know, so many of these things we talk about, there is no definitive answer. There is a consensus view, but you do have to adapt it around the individual. So, but obviously I'm right. So if there's a difference of opinion, and usually it'd be somebody, one of the younger ones, and they just need a bit of education, really.
We just checked, actually, it's Dr. Andreas Kramer that's joining us next week.
Oh, no, you know, Andreas, now he does know a lot, and he is impossibly young and handsome.
Yes,
although he did try and kill himself with his car boot. So somebody asked him, how's his head doing after he shut the car boot on it?
I'll start the conversation with that next week. Thank you. Right, okay, thank you very much, Dave. Thank you to everyone who's joined us as well. Take care. See you later. Bye. Bye.